do because we have a lot of speakers and it's 8 minutes per talk. So let us go on to the first talk, and that is by Dr. Rupal. And I think, as you all know, that she's one of the leaders of refractive surgery and has pioneered a lot of FDA trials for the SMILE procedure as it is known today. She is the medical director and head for Center for Sight at Vadodara, and she'll be talking about back to surface, I think, PRK, right?
PTK Art and
PTK.
Science.
PTK, sorry.
Art and Science.
Dr. Rupal, please.
Thank you, Dr. Maipan, for these kind words. If you, good evening, everyone. And I would like to give a special thanks to the organizers, but a real special thanks to Dr. Namrata for organizing this. Are you able to see my screen?
Rupal, you have to open the PowerPoint. There's some Excel.
Yes.
Yeah.
So you can see my screen, right?
Yes, ma'am. Just
Okay.
PowerPoint.
I'll just open the PowerPoint and make it full screen.
You have to first unshare what you're already sharing.
That's
Yeah,
fine.
now
It's
it's perfect.
That's fine.
Now has it come?
Yeah,
Yeah.
just go to full
Yes, ma'am.
screen.
Yeah.
Just go to full screen.
Yes. Is it happening?
No, you come down. Yeah, that's fine. Good.
Okay. So a special thanks to Dr. Namrata. And if you all are wondering why in a refractive surgery session, we are talking about PTK, which is phototherapeutic keratectomy, let me tell you that's the best way you can utilize your excimer laser. So I'll just give you a brief on the art and science of phototherapeutic keratectomy, which is another great way of optimally utilizing your excimer laser. The objective of PTK is to remove or for the treatment of diseased corneal tissue. This can cause an improvement of best corrected visual acuity. Sometimes it's used for elevation of visual symptoms such as monocular diplopia, starburst, or glare. Sometimes it's done only for non-visual symptoms such as pain, foreign body, and other symptoms. And simply for improvement in cosmetic appearance of the eye, PTK still can be used. The rationale for PTK is that the excimer laser has the potential for removal of diseased corneal tissue. And this was recognized right from the very beginning of the ophthalmic excimer laser's career. The lamellar structure of the cornea lends itself very well to the excision of diseased superficial tissue, leaving a healthy cornea behind. And this is what really helps. Manual keratectomy is often unsatisfactory for all except the most superficial lesions because it can cause scarring and opacities on the cornea. So alternative includes lamellar or penetrating keratoplasty. But the excimer laser has very special properties. It can remove precise amount of tissue, leaving behind an absolutely smooth bed with no collateral damage to the surrounding tissue. And therefore, it can be applied with in various corneal conditions like recurrent corneal epithelial erosions, band-shaped keratopathy, corneal dystrophy, recurrent pterygium, and so on and so forth. You can compare it with lamellar keratoplasty because in all this, lamellar keratoplasty would also work that well. But the advantage of having a PTK procedure done is that it's a simpler technique. It's cheaper because you don't require this donor tissue, which is really so much scarce and in demand. And the recovery is very fast without the need for much steroids. And therefore, it does lend itself to a very advantageous position. However, the disadvantage or the limitation of this particular procedure as compared to lamellar keratoplasty is that you can treat only pathology which is limited up to 100 to 150 microns of the very superficial lesions, and the induced hyperopic shift can be quite significant. So you need to learn the procedure and the application really very well. So that was the science. The art is to know whom you should be treating and how you should be treating correctly. Our experience is mainly for corneal dystrophies, for treatment of corneal erosions and treatment of recurrent pterygium. And I would like to share an example of a corneal dystrophy. It's a patient, male, age 48, with diminished vision since childhood. There is family history of progressive diminution of vision, and other family members also having similar affection. The best corrected vision when we saw him was in the right eye 624 and in the left 636, with a very high astigmatism of -4 diopters. So we first attempted PTK on the left eye on 24th March of 17. And this is what it looked like on slit lamp before the surgery. 2 weeks post-op, you can't believe this is the same eye. The uncorrected vision was 624. However, the best corrected vision with plus 2.5 diopters was 69. So we realized that it was causing a lot of hyperopic shift. And therefore, when we did the other eye, we made compensation for that. This is the OCT comparison. The upper part shows the dystrophy in place. The lower one is after the PTK procedure. For treatment of corneal dystrophy, laser can remove tissue from the first 100 microns or so. So you have to design the laser in a way where you want to, the depth at which you want to go and try and remove that much. Treatment of very deep layers could lead to a massive hyperopic shift or ectasia, and therefore it is not really advisable. We remove the epithelium mechanically or with the laser, and the laser is then free scanned to remove scar tissue layer by layer. And you do need to use a technique of smoothing in order to get an exact final outcome. Now, if you scan the laser without any fluid, you'll be mimicking the same opacities which are there at a lower depth with very little benefit. So even if the opacity becomes less, you would still have not so great vision coming up because of the irregularity still persisting. That's why you need to scan with the fluid in place so that the first few shots of the laser goes only through the fluid. The next one goes through the projecting abnormalities and the fluid. And ultimately, you can come down to a layer where you are removing all the opacities along with the irregularities. And that's the endpoint that you are wishing. As regards recurrent erosions, we know the basic pathology, so I'm not going into that. What we do there is to remove all the loose epithelium, and the defective corneal bed is smoothed with laser in the shaping mode. And then you take the laser to a spot mode where you can actually control the frequency with which you can pound those laser shots. And the marginal epithelium is then pounded with these high energy density shots. This is like doing epithelial puncturing. And the eye is then pressure patched and allowed to heal, and you can have results like this. The slide to your right shows the epithelial erosion, and you can see that the area extends right beyond it and also encroaching upon the epithelium, and not just the abraded area or the eroded area. So you need to remove the epithelium in all that, smoothen or remove the defective basement membrane. And you know that once you have an excimer laser removing any membrane, you get a pseudomembrane formation, which has a much better adherence to the epithelium now. So the slide to your left shows 2 years post-op picture, and you can see that it's as smooth as a normal cornea. As regards recurrent pterygium, if the corneal bed reepithelializes very quickly after surgical excision, then it can prevent recurrence. More importantly, in recurrent pterygium, because there are different planes which have been crossed, you can leave behind a very big opacity if you don't use the excimer laser. This is one such example. The slide to your left upper part shows the pterygium. The slide to upper right shows immediately after excision. But if you just leave it at that, you can imagine how much of the corneal opacity can be left behind. So the slide to your left down is the one which is showing after excimer laser how much of the clearance you can make or smoothing of the corneal bed you can make. I'm sorry, it is inverted, but that's the slide of the same eye. And this is after the healing of the epithelium that you can see. This is 2 months post-op picture. So you can imagine you've also not just removed the pterygium and prevented recurrence, but you've also been able to give a good visual outcome to these patients. The complications that are possible is reactivation of infectious keratitis in case you are trying to remove an opacity which is caused due to infection. There can be microbial keratitis, there can be delayed reepithelialization, recurrence of the initial condition, great hyperopic shifts, stromal haze, or sometimes even a perforation if you've been too overzealous in your treatment. But if you learn the procedure very well, you would find that PTK is a very effective technique and it's very well tolerated with significant and varied clinical applications, leaving this so precious corneal tissue for the real indications that they are meant for. So even if we can reduce the need for use of these tissues by 10% by using these PTK techniques, I think it would be a great service that we would be doing. Thank you.